Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article, Radiofrequency Ablation versus Stereotactic Body Radiotherapy for Localized Hepatocellular Carcinoma in Non-Surgically Managed Patients, Analysis of the National Cancer Database, by Rajaguru et al. My name is Ann Covey, and I am a professor of radiology at Weill Cornell Medical Center and an attending radiologist at Memorial Sloan Kettering Cancer Center in New York City. My specialty is interventional oncology. Hepatocellular carcinoma is the second leading cause of cancer-related death worldwide, and both the incidence and prevalence is on the rise, affecting approximately 6 per 100,000 in the United States. Increased incidence is due to several factors, including immigration, chronic hepatitis C, often contracted decades earlier, and metabolic syndrome. Expected 5-year survival in the 1990s was less than 5%, and with improved detection and treatment options is now approximately 20%. Most patients develop hepatocellular carcinoma in the background of cirrhosis that complicates and sometimes limits curative treatment options. For example, a patient with an otherwise resectable tumor might not be a candidate for surgical resection based on compromised liver function. The Barcelona Clinic liver cancer staging system takes into account factors related to tumor, liver function, and performance status to guide treatment. Curative treatment options for hepatocellular carcinoma less than or equal to 3 centimeters, based on the Barcelona Clinic liver cancer staging schema and the National Comprehensive Cancer Network guidelines, include transplant, surgical resection, and ablation. In the 1990s, prospective trials comparing ethanol ablation and radiofrequency ablation, hereafter referred to as RFA, of small hepatocellular carcinoma showed better outcomes for ablation compared with ethanol injection and overall survival comparable to that seen after resection. This prompted prospective trials directly comparing RFA to hepatic resection. Since, there have been 4 prospective trials including over 600 patients. 3 of these randomized trials were included in a meta-analysis published in a 2014 +1 article by Wang and colleagues showing no difference in overall survival at 4 years in patients who underwent RFA or hepatic resection. Most of the data for stereotactic body radiotherapy, hereafter referred to as SBRT, are small, retrospective, single-institution studies, and to date there are no randomized studies comparing SBRT to either RFA or surgical resection. One of the larger retrospective studies was from the University of Michigan, published in 2015 by Wall et al. In Journal of Clinical Oncology. This study included 161 patients who underwent RFA and 63 who underwent SBRT for tumors with a median diameter of 1.8 and 2.2 centimeters respectively. This study included tumors up to 7 centimeters in the RFA group, which is beyond the range for curative intent, and 10 centimeters in the SBRT group. They found no difference in overall survival at 1 and 2 years, but better local control in the SBRT group for tumors larger than 2 centimeters. To date, this has been the best data we have comparing RFA and SBRT, and it's unlikely that prospective randomized control trials will be forthcoming because of the logistical complexity and expense associated with trials comparing outcomes of interventions performed by different specialties. In the manuscript that accompanies this podcast, Rajaguru et al. Performed an observational study to compare overall survival of patients with early tumors, defined as T1 or T2, without nodal or metastatic involvement, who underwent either RFA or SBRT as primary treatment without adjuvant or neoadjuvant chemotherapy. This includes patients with solitary tumors, with or without vascular invasion, and multiple tumors up to 5 centimeters in size. The data set comes from the National Cancer Database, which includes patient, tumor, treatment, and outcome information of approximately 70% of all newly diagnosed cancers in the United States. In this data set, between 2004 and 2013, there were 47,634 patients with newly diagnosed T1 or T2 hepatocellular carcinoma without nodal or metastatic disease, representing approximately 40% of all new cases of hepatocellular carcinoma during that time. Of these, 3,684, or 7.7%, underwent RFA, and 296, or 0.6%, SBRT as primary treatment. As one might expect from an observational study, there were some significant differences between the groups. Patients who underwent SBRT were older, more often white, and had fewer comorbid conditions. SBRT was also used more often in patients with larger tumors and low fibrosis score when the fibrosis score was reported. Geographically, SBRT was more common in the Northeast and also more common in the later 5 years of the study. Because of the magnitude of difference between the number of patients who underwent RFA compared to SBRT, a 2-to-1 propensity score match was used. With a median follow-up of just over 2 years, RFA was associated with a significant benefit in overall survival of 10.4 months, with a 5-year overall survival for RFA of 29.8 months compared to 19.3 for SBRT. The benefit of RFA was consistent across all subgroups examined. One interesting finding of the study was that the overall survival was significantly better in the later time period, 2009 to 2013, for patients treated with RFA. It seems likely that this reflects our better understanding of the importance of achieving complete ablation with adequate margins and improved imaging tools to evaluate and ensure treatment margins at the time of the procedure. Survival following SBRT was unchanged between the time periods, which may be due to the relatively small group of patients who underwent SBRT in the earlier period. This study is broadly generalizable because of the large number of patients included from all areas of the country, different hospital settings, and a variety of financial means. The primary clinical outcome, overall survival, is arguably the most important outcome, but may be influenced by subsequent treatments that are not enumerated in this data set. There are also limitations to the study. For one thing, ablation was performed using only radiofrequency ablation. Currently, ablation is often performed with more powerful forms of heating, including microwave, that may increase the size of tumors that can be treated and may also improve outcomes after treatment of smaller tumors. This study also included a heterogeneous group of patients ranging from patients with solitary 2-centimeter tumors to multiple tumors up to 5 centimeters with vascular invasion. While outcome was better for RFA across all groups studied, it is conceivable that patients with vascular invasion, a marker of aggressive tumor biology, were preferentially treated with SBRT because these tumors are difficult to completely treat with RFA alone. Most patients in this study received 50 gray or less in 3 to 5 fractions. Recent data from a phase 2 trial suggest higher doses using proton beam therapy may improve survival and also may spare more non-tumor-bearing liver parenchyma. Sparing non-tumor-bearing parenchyma is important in SBRT because SBRT has been associated with decline in liver function as measured by Child-Pugh classification. A prospective phase 1 study at the Princess Margaret Hospital found decline in Child-Pugh classification at 3 months in 16% of patients with hepatocellular carcinoma who underwent SBRT. In the more recent study of 44 patients with hepatocellular carcinoma who underwent a median dose of 58 gray with proton beam therapy, only 3.6% had worsening of their Child-Pugh score. Earlier detection due to improved screening programs will likely increase the number of patients with small tumors eligible for RFA and SBRT. Exciting new technology in ablation, including improved assessment of treatment margins and the ability to create larger ablation zones, and in radiation oncology, including proton therapy, continue to improve the outlook for patients with hepatocellular carcinoma. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.